your moderator for today's session. We're truly delighted to see such enthusiastic participation from students, interns, optometrists, and professionals who are keen to strengthen their foundation in pediatric contact lens practice, an area that is both challenging and extremely rewarding. It is now my privilege to introduce our and everyone please mute your mics. It is now my privilege to introduce our esteemed resource person for today. We have with us Mr. Syed Imran. Imran sir is a graduate from Centurion University and has also pursued his master's from Sankara College of Optometry CT University. He's a former contact lens practitioner at Vishakha Eye Hospital and has also worked as a research optometrist at LVPEI. With a strong academic background and hands-on clinical experience, especially in contact lens practice, he's exceptionally well suited to guide us through the fundamentals of pediatric contact lens fitting and help us understand how to start strong in this field. We're very grateful to have you with us today, sir. But before we begin, a few quick instructions for the participants. Kindly keep your microphones muted throughout the session. This will be followed by an interactive Q&A session at the end of the presentation. You may post your questions in the chat box during the session. Selected questions will be read out and the speaker will address them one by one. I request everyone to stay till the end to gain maximum benefit from today's discussion. Without any further delay, I now invite Syed Imran sir to begin the session and enlighten us on contact lens in pediatric. Start strong. Over to you, sir.
Hi, hello, good morning, everyone. Thank you, Sazia, for this kind introduction. So today we are going to discuss about a very interesting topic, pediatric contact lenses, and how you can start your practice in that. So first, let me share my presentation. Well, I hope that the presentation is visible to everyone.
Yes, sir, it's visible.
Know that fitting contact lenses in any age category is an technical skill. So especially when you're dealing with kids, it requires more patience, it requires more precision, and you need to be very thorough with your technical skills. So as you all know that children can be very uncooperative even while just while you are doing objective retinoscopy such as retinoscopy. So objective refraction such as retinoscopy. So they'll not fixate at one particular distance. They'll tend to move from here and there. So it will be very uncooperative. So you just imagine if you're trying to insert a contact lens into a child, how uncooperative they can become. So before prescribing any contact lenses to children, the factors that you have to consider is that it should be dependent on the specific ocular condition rather than age. The age can be anything. It can be around in the months or in the years or early years of the life. But if the kid needs contact lenses, if the kid needs contact lenses for their visual development, then you have to guide them and you have to give an option of contact lenses as a management. Okay, so in which conditions then we can consider giving contact lenses? The first and very important condition is pediatric aphakia, where many of the congenital cataract cases happen, and the surgeons will not do IOL implantation until the child is fully matured. Only then the IOL implantation can be done. But before that, the child will be left off very huge amount of anisometropia, very huge amount of high refractive error. So in order to correct that, you need to give contact lenses. And the second condition is high anisometropia, as I said earlier. And in cases of irregular astigmatism, in cases of trauma, and in some cases of aniridia or iris coloboma, you can also consider contact lenses. In very rare cases, albinism, in albinism also you can give contact lenses as an occlusion therapy for amblyopia and for nystagmus. So these are the usual conditions in which you can give contact lenses. Okay. So types of pediatric contact lenses. This is quite similar to the adults. Like how adults can be given contact lenses, the same type of contact lenses can be given to children as well. Like soft lenses, your RGP lenses, your prosthetic contact lenses, mini scleral lenses, and ortho lenses for myopia control. But some modifications that had to be done if you are prescribing for a child, we'll discuss it about in the later slides. Okay. So what are the factors that you have to consider? The first is the visual need. As I said earlier,
Hmm.
the child's specific condition is very much important rather than
Hmm.
age. And maturity and responsibility. You have to see that the child can follow the lens care and the hygiene protocols. For a successful pediatric contact lens fit, both the child and the parent must be fully committed to the contact lens. Even if one of them is not agreeing on you completely, then it will not be a successful fit, because the the kid will wear the lenses, but it is the parent's responsibility that they have to look through the care and the hygiene of their kids contact lens. So it is very much important to both be on aboard when you are trying to give and trail for the contact lens. Okay. So what does the literature say? The literature says that if you're starting contact lens practice at a very early age, there is a high success rate of around 80 to 90% if they are starting very early. And comparatively, soft lenses are a better option compared with the RGP lenses, because it has more comfort, and they're able to tolerate it much more easily than the RGP lenses. The key for an successful contact lens fit is structured training, parental involvement, an appropriate lens selection, and very regular follow-ups. These are the four things that you have to be very sure if you want an high success ratio. Okay. So, who all should be present in the management of the contact lenses in kid? The first is your CL practitioner should be there, and the second, pediatric optometrist and ophthalmologist, because they need to do the refraction before going into the contact lens. So they'll give you refraction values, and they'll tell if if the child's ocular surface is fine, are they having any complications, or are they are not indicated to use contact lenses. You'll get all those information from them. And obviously the parents also should be there, because they need to learn how to insert and remove the lens on their kid, and they need to learn how to do proper care and regimen. So these are all the members that have to be present in the management of pediatric contact lens fit. Okay. So there is a slight difference between the parameters that you consider in adult and in the children. So in adults, you'll consider the HVID diameter and your anterior corneal curvature, your flat K values. These things you'll consider, and you will see if the ocular surface is fine or not. But in children, it is a little bit different. The first thing you have to consider is your palpebral aperture size, because the kids' eyes are very small. Their palpebral aperture will also be small. So you need to make sure that whatever diameter that you're selecting, it should be in the range of the child's eye. And as you all know that the children's eyes are small, so smaller the eye, steeper will be their corneal curvature. So you have to look for that also. So if you have taken the K readings, and you have taken flat K of around 42 diopters, so you need to give them 1 or 1.5 mm steeper than the flat K. So because their anterior curvature is steeper than your normal usual adult. And you also look for the tear reflex, because in the early stages of life, the children will not develop tears, they will not have the tear reflex. So you need to make sure which type of contact lenses you are prescribing at which age. And there is an axial length change in refractive status of the eye. You have to look for that also, because for every 6 months or for every 1 year, the axial length will change, and the refractive status of the eye will also change. So according to that, you have to reconsider the lens fit, you have to reconsider the lens power and everything. Okay. So these are all the parameters and the factors that you have to consider before fitting an contact lens to a kid. Now we will move on to an interesting condition, aphakia. In Aphakic, how can you prescribe contact lenses, and what is the calculation that you have to do, and which type of contact lenses are better at which age? We'll discuss all those in this Aphakic. Okay. So as you all know that pediatric aphakia will cause high amounts of hypermetropia. It can also cause anisogenia, which in turn results into amblyopia. So early optical correction is very much important for their critical visual development. Contact lenses will provide better image quality compared with the spectacles because they are directly lying onto the corneal plane rather than on the spectacle plane. So what happens if your power is based on the spectacle plane? It will cause magnification, it will cause distortion, which will in turn result in anisoconia, which is not at all helpful for complete binocular vision development. So that's the reason we'll choose contact lenses over the spectacles. So what are the advantages? Like why contact lenses are considered in FAK? As I said, it provides a very clear retinal image. It also reduces anisoconia. It helps to improve the binocular vision, and it also has a better cosmetic appeal. For example, if you prescribe an plus 14 diopters of power to an infant of 7 months old, he starts to wear spectacles. And some of the time, whenever the parents, family members, or any other relative sees the kid, and they'll ask many n number of questions to the parents, like why he's wearing glasses, what is the condition that he's having. So they have to answer lots of questions. But if the infant is wearing contact lenses, no one will know what is happening with the child. They will see that the child is very normal. So it also helps to bring the cosmetic appeal. And the fifth point is that it also allows to change the flexibility of the contact lenses as the eye grows. So as the eye grows, the power also changes. So you have to change the lens according to that. So this lens, sorry, is anyone talking? Anyone trying to speak?
No, sir, no, sir.
Okay.
It was a mistake, I think.
Okay. So this is the reason that we'll consider contact lenses in the cases of aphakia. So type of contact lenses that you use for aphakia. You'll use RGPs, you'll use silicone elastomer lenses, you can use soft lenses such as HEMA and silicone hydrogel lenses. We'll see what are the advantages and the disadvantages of these particular lenses. Okay. So RGPs have excellent optics. They are very durable, and they tend to correct very high amounts of irregular astigmatism. So the only disadvantage is that they'll have initial discomfort. Like adults cannot bear wearing RGBs for around 1/2 an hour. So you have to assume how kids can react when we are giving them RGB contact lenses. But uh, the tolerance rate of children is more compared with adults. So that's why we can use RGBs in infants and in children. The second lens that you can prescribe is silicone elastomer lenses. These are having high dk by t value, and they are very flexible. But the only con is that silicone elastomer lenses are hydrophobic in nature, so they tend to attract more deposits. So which in turn will damage the contact lens. So they have to change the lens thoroughly. They have to change the lens for every 4 months or every 5 months, which will in turn increase the cost ratio. So that's why it's best used in only infants, because these lenses can be worn for around 15 to 20 days without removing. So that's the reason we'll consider these lenses only in infants. And the hydrogel lenses, like HEMA lenses and your silicone hydrogel lenses, both can be given to older children. But in silicone hydrogel, there are power limits. You cannot give high power ratio. In hydrogel HEMA lenses, the oxygen permeability is less. So these are the advantages and disadvantages of the different lenses, and in which age group that you have to consider them. So application technique. So this is quite different. For adults, you'll use your hand, and if you are the practitioner, you are inserting the contact lens. You'll place the lens on your index finger, and with the other three fingers, you'll hold the upper lid and lower lid, and you'll gently place the lens either onto the cornea or onto the nasal or temporal side of the cornea. But coming to the pediatric contact lens application, it is different because children are very uncooperative. The first thing that you have to do, you have to sedate or do a child restraint, because they'll move, and you have to take the contact lenses into your hand, and you have to pinch the contact lens. With the other hand, you will open the both eyes, and you will gently place the lens onto the eye. So this is how you will insert the lens in an pediatric patient. So as you can see, the practitioner here is holding lens in a pinched manner, and he's using the other fingers to open the eye completely, and is slightly gently placing the lens onto the cornea. This is how you should insert contact lenses into a child. The normal adult approach will not work. This is the approach that you have to learn. Okay. So coming to the contact lens power calculation. So you know that when you are prescribing contact lenses, you have to look for vertex distance compensation. That is what vertex distance compensation is a thing where when you are doing refraction, you will do refraction on a spectacle plane. So if you want to prescribe for the corneal plane, you have to do a vertex distance compensation. Suppose there is a case example that I have written over here. A 3-month-old infant has bilateral aphakia with refractive error of around plus 14 diopters, measured with retinoscopy. Then what will be the contact lens power for that patient? So assume that the vertex distance is around 12 mm, which is around 0.012 mm, 0.012 meters. The formula is f spherical by 1 minus d into f spherical. If you do that formula, you will get around plus 16.82 diopters, or around plus 17 diopters of power for the contact lens. This is the contact lens power that you have to prescribe for that child with the refractive error of plus 14 diopters. Okay, this is how you will do your contact lens power calculation. This is for the cases of aphakia. Uh, until now, I think I hope that it is clear for you guys. So now we'll start on ortho lenses. Right now, it is very popular now, myopia control, because everyone is looking different methods to control the myopia progression. So what is orthokeratology? And orthokeratology is a special type of lenses where they temporarily reshape the cornea and allows the visual acuity to increase without the use of any lens after the day. So orthoke lenses are specially designed rigid gas mobile lenses. These lenses are meant to be worn overnight. It's not meant to wear in the day. It's meant to be worn overnight, and it temporarily reshapes the cornea, which will provide a better, clear, unaided vision during the other day. Now, how does it work? The central cornea flattens, which will in turn corrects the myopia. The peripheral, which is the treatment zone, the reverse curve zone, it creates an peripheral myopic defocus, which will in turn helps in slowing the progression of myopia, because this peripheral myopic defocus also slows the axial elongation. This is how the orthoke lenses work in the cases of pediatric patients. So in which conditions that you can prescribe orthoke lenses? The first, it should be progressive myopia. So there are different type of myopia: refractive myopia, index myopia, curvature myopia, pathological myopia, and axial myopia. These lenses will only work in the case of progressive myopia, which is axial myopia, where the axial length changes for every 1 year or every 6 months. Because of the change in axial length, the myopia also changes. So in only those conditions, you can prescribe orthoke lenses. And the power should be around minus 0.75 to minus 6 diopters. The astigmatism should be minus 1.5 to minus 2 diopters. In the range of this, it should be in the with the rule. The lenses won't work if it is in the against the rule or the regular astigmatism. Okay, and there should be a highly motivated child and with very good parental compliance. These are the indications in which you can give contact orthoke lenses as per the myopia treatment. So as I've said earlier that overnight corneal shaping will in turn result in clear vision, and it creates peripheral myopic defocus. Because of that, the myopia will not progress. But the difference between the adult orthoke lens and the child's orthoke lens is that the treatment zone diameter. For adults, the treatment zone diameter will be more compared with the child. Child will have smaller treatment zone diameter, which will create spherical aberrations, which will in turn helps in creating myopic defocus. So that's the reason we'll select only the smaller treatment zone diameters for children. Okay. So this is one of my patients where I have this is an adult. So I just want to give you how this ortho lens looks like. So as you can see over here, this is the treatment zone. It's around 6 mm, and this is the reverse zone diameter where the peripheral myopic defocus happens, and this is the peripheral area where the lens sits. So this is how an ideal lens should look like when you are prescribing the ortho lens. Okay. So now we'll look for some of the case scenarios, what I've discussed earlier. History. A 3-month-old infant presented with bilateral congenital cataract surgery. Parents report poor visual attention because of high amounts of hypermetropia. As you have examined, there is aphakia in both eyes. The cornea is clear. IOP is also normal. Poor fixation is there because of uncorrected refractor. In this case scenario, the management plan includes the first, it is the infant is fitted with silicone elastomer contact lenses and full hyperopic correction was given, regular follow for every 4 to 6 weeks, and the parents are trained for the lens insertion removal and hygiene. This should be the management plan for this particular case. Now we'll go for another case, second case scenario, where a 5-year child with a history of traumatic cataract surgery has been done. The right eye is aphakic, left eye is normal, which in turn results in high anisometropia. Because of high anisometropia, the child is turning into amblyoptic. As you can see, suppression is noted on both for dot test. So for this patient, the management plan includes the patient was given with RGB lenses fitted in the aphakic eye. Spectacles were prescribed over the contact lens. Amblyopia patching therapy was initiated, and close monitoring was done. Now you can ask the question that why for an first case we have fitted silicone elastomer lenses, and for this case we have given RGB lenses. I'll explain you. So the first case, the child is an infant. For that, if it will be very uncooperative if the parents are inserting the lens for every day and they are removing the lens every day. So what happens with silicone elastomer lenses? These can these are extended wear lenses where you can once if you are inserting the lens for around 15 to 20 days, the child can go on with that lens. So it will be minimal hassle compared with the RGB lenses. And with RGB lenses, the child will also have much more discomfort. When in the second case, we have given RGB lenses. Why? Because as it is a case of traumatic cataract, we can assume that there might be some amount of irregular astigmatism. So for that amount of irregular astigmatism, only RGB lenses can correct that. So that's the reason we have given RGB lenses, and spectacles were prescribed over that contact lens. Because RGBs cannot come in huge amounts of power. It cannot come in plus 14 or plus 15 power. So how much amount of maximum power that you can correct through the RGB, and based on over that you will prescribe spectacles. So that's the explanation between the management plan between these two cases. Okay. Now for an myopia control case, this is a 10-year-old male who has been using spectacles for past few years, but the parents were concerned about the increase in the refractor error for every year. So they came for an ortho trail because they know what ortho lenses are. They have done their research and they came for an ortho trail. So while looking at the previous refraction values, as you can see for 2022, the child's refractor error was around -2.5 and -1 diopters. For 2023, it was -3.25 diopters. And for 2024, it was around -4 diopters. So for every year, there is an increase of -0.75 diopters in the spherical power, which is not good. So what we have to look for in this case, there is an increase in the refractor error of 0.75 diopters in every year with the rule astigmatism because it is in 180 degrees. Examination of complete ocular surface to check if the child is an ideal candidate for the trial. You have to look for all these. Only then you have to consider the ortho case. We have checked all this. There is an increase in 0.75. There is with the rule astigmatism, and we have done complete ocular surface trial, and you know that the child is an ideal candidate for the trial. Now we have prescribed contact lenses. How you have prescribed? Ortho lenses was fitted according to the refractor error HYD parameters were entered into the Ortho lens calculator. There is an app known as Paragon CRT app, which is available in App Store and the Play Store. You can download that app and you can see, you can enter the refraction values and you'll enter the HYD values. It will give you an contact lens power and the reverse zone diameters, how much amount of reverse zone diameter should be there. And by according to that, you will fit the contact lens. And after that, you will see the topography. If you are observing bullseye pattern, then the lens is working properly. If you can assume that it is an optimal fit, and you can prescribe that lens. And as you have noted, progression has decreased from -0.75 diopters to -0.25 diopters in 1 year. So this is how you will prescribe for an child. This is how you will prescribe ortho lens for a child. Okay. So we have discussed on aphakia, we've discussed on myopia control ortho lenses. In my second slide, I have explained there are other conditions in which you can give contact lenses. So we'll discuss about that. In the case of aniridia is an absence of iris. The preferred lens will be prosthetic soft or scleral lens. The main purpose of that lens is to reduce the photophobia and to improve the cosmetic nature. So what happens in aniridia, as there is no iris completely, the light enters completely into the eye, which will cause photophobia, which will cause glare. So the patient will not be able to see in bright sunlight conditions. So that's the reason you'll opt for prosthetic lenses, either soft or mini scleral lenses, which will reduce photophobia and which will also improve the cosmetic appeal. In the case of iris coloboma also, you can prescribe prosthetic soft lenses, which is similar as your aniridia, where you're controlling the glare and you're improving the cosmetic appeal. If there is any corneal irregularity in that conditions, you'll prescribe RGBs or mini scleral lenses for improving the vision. Okay. Now, I've also said in albinism also we can give contact lenses. You know that in albinism we'll prefer some type of tinted spectacles for reducing the photophobia and reducing the glare. But you can also give them contact lenses like tinted prosthetic soft contact lenses, which will reduce the glare and photophobia. Custom prosthetic lenses, which will control the light entry and improve the cosmetic appeal. RGB lenses will improve the optical quality, and scleral lenses will improve if they are having any ocular surface disease or dry eye or anything like that. You can opt scleral lenses in such conditions. So in albinism also, you can consider contact lenses as their management option. So you are fitted in contact lenses. After 1 month or 2 months, the patient comes again with a problem. So now you have to see what is the problem and how you can correct it. So if the patient comes with an handling or compliance problem, then you have to instruct the parent again and you have to shift them to daily disposable lenses, as it is an easy. But if the patient complains of comfort and adaptation issues, if the patient complains of any foreign body sensation or any pool tolerance, shift from RGPs to soft lenses. It will have more comfort and the patient will be able to tolerate much more easily. If the patient is having lens related problems, they say that the lens is not staying center or the lens is having any deposits, so then you have to adjust the fit and you have to reassess the fit. If the patient is having redness or hypoxia, the first thing you have to do is ask the patient to discontinue the lens, treat the condition. I'm sorry, you should not treat the condition. You should send them to an ophthalmologist. There they'll treat the condition, and after that, even after that, if they are still agreeing to use contact lenses, then switch them to high decay lenses. That will be a better option for them. If they're having vision problems, their vision is not clear, then you have to recheck the refraction. You have to do the over refraction again, and if there is a risk of amblyopia, then you have to send them to vision therapy. You have to treat the amblyopia first, then you can prescribe them contact lenses. Okay, this is how you will manage different type of conditions and can overcome them. Okay, so the take home message is that pediatric contact lenses fitting is safe and effective with proper case selection. You have to see which case the contact lenses can be benefited, in which case it is not benefited. The age alone is not a contraindication. As I've said earlier, age is not in priority over here. The ocular condition is in priority over here. You have to explain thoroughly to the parent if they are not used contact lenses, or if they're not opt for early optical correction, there might be a chance of amblyopia, and the child may not be getting the full vision. If they child may not get the full vision in the later stages of life. So, as I said, contact lenses are preferred in pediatric aphakia and high anisometropia. Lens selection must be individualized using high oxygen permeable materials. You have to only choose high DK by T materials. Regular follow-up is very much essential for an successful contact lens fit. So this is how you will start your pediatric contact lens fit. The first thing that you have to be is very confident, and you should know what to do in which condition, and what are the contraindications, what are the indications of pediatric contact lenses. I hope this PPT has given you some insights on this particular matter.